Morning, everybody. So thank you very much for asking us to speak today. So yes, my name is Caoimhe Tennyson and I'm one of the Perioperative Medicine Fellows in UCLH. And again on the call today is Dr. Isra Hassan, who is one of our perioperative consultants and is also a consultant anaesthetist in UCLH as well as Cardiff and Vale University Health Board. So today I'm going to speak about the new guidelines that have just been published in January by the Association of Anaesthetists regarding the perioperative management of unhealthy alcohol intake before surgery. What we'll look at today is the burden of unhealthy alcohol intake, the preoperative best practice screening, recommendations, considerations, and then we're going to look at the two main flow charts, one for non-emergency surgery and one for emergency surgery. So alcohol moderation in the perioperative period, why does it matter? So the WHO has highlighted that at least 2.6 million deaths per year can be attributed to alcohol consumption, which is around 4.7% of all deaths, which is a huge number. And we feel that this can be reduced significantly with ongoing education and support provided to the public, especially by us anaesthetists. So a higher than advised alcohol intake in the perioperative period poses its own sets of risk, and we will speak about this later on in the presentation. But now it is advised that men and women alike only consume up to 14 units of alcohol per week if they are drinking alcohol. And in consuming those 14 units, they should do so over at least a 3-day period. So the Office for National Statistics up to April of 2024, they highlighted that in 2022, over 10,000 deaths, which was the highest on record, were alcohol specific. And that was 4.2% higher than in 2021 and 32% higher than in 2019, which was pre-COVID. And the findings also revealed that Scotland and Northern Ireland had the highest rates of alcohol specific deaths in 2022. As a result of this, the British Liver Trust is calling for the government to deliver a comprehensive alcohol strategy and is suggesting the UK government reinforce public health measures that address the affordability, promotion and availability of alcohol to reduce its harmful impact. So what are the perioperative implications? So 1 in 5 surgical patients has an alcohol use disorder. These can cause systemic effects. There's risks of alcohol withdrawal syndrome causing increasing morbidity and mortality. There's an increased risk of other complications, be it respiratory, arrhythmias, coagulopathies, infection, peptic ulcer disease. This is not only an increased cost to the patient themselves, but also increased cost to the hospital with an increased length of stay. So early identification of these alcohol use disorders may help to reduce these perioperative complications. Now this looks like a very busy slide, so I'm just going to go through a couple of the main issues here. So the systemic complications that are so important in the perioperative period. From a hepatic point of view, so fatty liver, alcohol, hepatitis and cirrhosis. So it's so important for us anaesthetists whenever it comes to medications that we give these patients. Immunological, increased susceptibility to infections, altered immune responses, which again is so important for recovery in the perioperative period. Cardiac, hypertension, cardiomyopathy, peripheral vascular disease, heart failure, arrhythmias, which again can be at increased risk in the perioperative period in general. Renal, CKD, dehydration. From a GI point of view, is an increased risk of gastritis, peptic ulcer disease, and malnutrition. Neurologically, there is alcoholic neuropathy, Wernicke's and Korsakoff syndrome, seizures, CVAs. Psychological, there's an increase in mood changes in depression, anxiety and paranoia. And from an MSK point of view, there's an increased risk of falls, sarcopenia leading to increased risk of fractures as well, and myopathies. So it is a very challenging group. So surgical patients with a history of unhealthy intake pose unique challenges to healthcare professionals during the perioperative period. And up until now, there have been no local or nationally agreed guidelines for the screening, identification and management of this group in the elective and non-elective setting. So just a very brief overview of some literature. So the best practice literature on the perioperative management of patients with the background of unhealthy alcohol intake is limited, to say the least. So PubMed literature keywords, if you type in perioperative management and alcohol, cited 627 articles. 12 of those covered perioperative management in patients with alcohol history, 8 of which were specifically for alcohol withdrawal management in the periop period, and 2 were specifically for the periop management of alcohol dependent patients. So if we look at the perioperative best practice, so we're going to look really at these first 4 points because they're to do with pre-op. We want identification in the preoperative setting. We're going to look at the Audit C tool further on. We're going to look at alcohol brief interventions, so ABIs, and then we're going to look at our gold standard preoperative investigations. So there is significant inconsistency in the perioperative screening and identification and management of these disorders. There's a variation in pre-assessment screening, there's a variation in practice and resources in hospital, there's significant implications for the timings of surgery and if your patient is presenting as an emergency or whether they're presenting for elective surgery, and it takes a complete MDT collaboration, including from the initial primary care referral, if that is where it starts. So these are the new guidelines. So as I said, published in January 2025 by the Association of Anaesthetists. And as you can see, Dr. Hassan, who is on the call today, she was the lead in developing these guidelines and was also a co-chair of the working party to develop them also. So this is a consensus document. It was produced by expert members of a working party established by the Association of Anaesthetists, and it is endorsed by an excellent array of people. And again, this endorsement was needed in order for us to be able to implement these guidelines. So it was endorsed by the British Association of the Study of the Liver, the British Society of Gastroenterology, British Association of Day Surgery, and the Royal College of Psychiatrists of Wales. So just a very, very brief overlook of the Delphi process, and this was the process that was used along with the Squires to implement or to look and develop these guidelines both locally and nationally. So if we look at the first point, the problem area. So what was our desired outcome? So it was to ensure patients were optimised adequately pre-operatively, to standardise patients' perioperative care whilst minimising potential risks. And the perioperative guideline in itself was developed using a series of open-ended discussion rounds amongst expert panel members using evidence of best practice and user feedback from healthcare professionals. So it's a pragmatic guideline for every anaesthetist and every healthcare professional that meets these patients preoperatively, and it is standardised for each patient. So the objectives. To standardise preoperative assessment for alcohol consumption using the national screening tool of Audit C, to standardise a list of best practice recommendations in the perioperative period, to ensure a multidisciplinary approach of coordinated care and to include who and when and how to contact the healthcare professional members needed for the perioperative pathway, and to standardise perioperative management using the surgical priority classification from P1 being an emergency right up to P4 an elective. So our Audit C screening, so 3 very straightforward questions. This shouldn't take much time. This could be done quickly in a pre-op assessment clinic or done quickly in primary care. And basically we're looking at the scores for these patients. So a score greater than 5 should prompt you then to go on to do a comprehensive audit score. So this is our audit scoring, 10 questions. Again, it's more in depth than our Audit C. And the comprehensive audit, less than 8 being low risk, 8 to 19 being an increased risk, and more than 20 being harmful drinking and dependence likely. So there were 10 recommendations, but the first 6 are the 6 to do with preoperative recommendations. So patients should be screened during pre-assessment for surgery using appropriate tools such as the Alcohol Use Disorders Identification Test for consumption, which we just looked at, our Audit C questionnaire, to triage risk relating to alcohol use. Those patients with harmful chronic alcohol intake or who are judged to be at high risk of alcohol-related liver disease should have careful preoperative physical examination and additional relevant investigations. So harmful intake was denoted by an audit of greater than 19 and/or consumption for women of greater than 35 units per week or for men greater than 50 units of alcohol per week. In preoperative patient populations, elevated questionnaire scores should prompt a proportional response ranging from your brief intervention, so your ABIs, to inpatient specialist referral. Patients who have previously demonstrated harmful alcohol consumption may still be at a high risk of alcohol-related liver disease, irrespective of current screening scores, and that is something we really do have to keep in mind. Risk assessment and decision-making in established alcohol-related liver disease should be guided via the use of validated scoring systems such as your SORT scoring, so your surgical outcome risk tool. The perioperative clinician managing harmful alcohol intake should consider surgical urgency according to the recognised classification system. Further pre-op considerations. So consent. Does the patient have sufficient mental capacity? Are they actively intoxicated? Are they encephalopathic? Do they have chronic alcohol-related brain damage? And again, it's important to keep in mind the Mental Capacity Act of 2005. Nutritional issues. So malnutrition is common in 60 to 85% of patients with cirrhosis, as well as frailty, electrolyte disturbances and vitamin deficiency. And then we have our screening, so our MUST score and our Royal Free Hospital nutritional prioritising tool, which as per the guideline is probably the better of the two tools, given the fact that it takes into consideration fluid overload and ascites in our cirrhotic patients. We will have dietitian input for complex cases, and we also have to consider, for example, iron infusions and those patients who are at particular risk of, for example, refeeding syndrome. From a haematology point of view, bleeding is considered likely, especially if the patient is having major surgery. We aim platelets greater than 50, fibrinogen greater than 1. At the minute, there isn't enough evidence on the use of tranexamic acid, but avoidance at high doses where seizure risk is elevated, so for example, with patients who are at high risk of alcohol withdrawal. Older patients are exceptionally vulnerable to the effects of alcohol. Harmful alcohol intake is actually an independent factor for the development of frailty and strongly associated with dementia, falls and delirium. Day surgery might be advantageous for these patients, but that is all depending on the surgical intervention that's required, individual patient characteristics and local resources. And patients who do present acutely intoxicated on the day of surgery should have surgery postponed with appropriate follow-up. So this is the first of our flow charts that are in the guidelines. This is for non-emergency surgery, so P2 to P4. So initially we'll see our initial screening, our audit C score that we've gone through. If it's less than 5, there's no further action required. An audit C score greater than 5, then again we proceed to our comprehensive assessment with full audit questionnaire. With our comprehensive assessment, our audit scoring, less than 8 being low risk, 8 to 19 increased risk, and greater than 20 is indicative of harmful drinking and dependence likely. And then if we just take a closer look at our comprehensive assessment, we want to assess the risk of alcohol-related liver disease. So our audit score greater than 8 and scores greater than 16 are particularly high risk. Current or previous alcohol intake, again for women, more than 35 units per week and men more than 50 units per week. Known complications from harmful alcohol intake and stigmata of chronic liver disease on examination. Then we have key investigations that we want to carry out, which include blood tests, ECGs with or without echoes, and specialist investigations like a fibroscan or a CT liver. Then going on to our pre-operative intervention. In all cases, feedback to the patient for reasons for intervention is important. We should also be performing risk assessment scores, whether that's SORT or PPOSM, and if the mortality is greater than 5%, we should be considering a critical care admission. So with our preoperative intervention, we want to reduce the alcohol consumption. Low risk, an audit less than 8, it's simple advice and education. An increased risk, audit 8 to 19, it's our alcohol brief interventions. So discuss the impact of harmful intake with the patient, give an advice booklet, and for those at higher risk, so audit greater than 16, you will consider community alcohol service referral and inform the GP. For harmful drinking or dependence, which is your audit greater than 20, for non-urgent elective surgery, we strongly consider community alcohol detoxification referral, and for urgent surgery, consider inpatient detoxification under drug and alcohol liaison team. Then for referral for suspected or confirmed alcohol-related liver disease, in our elective population, if clinical evidence of chronic liver disease or jaundice, we want to refer to hepatology as an outpatient and consider postponing surgery until after specialist review. If it's just for isolated deranged liver function tests, we want to refer to the GP for further non-urgent investigations and consider postponing surgery and consider a fibroscan or an ELF score, which is your enhanced liver fibrosis score. Then for urgent or expedited patients, if clinical evidence, again, of chronic liver disease or jaundice, it's going to be an inpatient referral to gastroenterology. And as an outpatient, that would be urgent outpatient hepatology referral. For, again, isolated deranged liver function tests in these patients, urgent outpatient hepatology referral and check if previous engagement with alcohol support service and consider fibroscan or ELF score. So then our second flow chart, which is for emergency surgeries. So again, our assessment is exactly the same as our previous. We start with our audit C scoring. Greater than 5, then perform our comprehensive audit score. Then with the audit score, we want to also consider other risk factors for these patients for chronic harmful alcohol intake. So are they acutely intoxicated? Do they drink more than 35 units a week for women or more than 50 for men? Do they have known cirrhosis? Is there evidence of wernicke's encephalopathy? Are there signs of chronic liver disease on examination? And is there deranged liver function, coagulation or low platelet count? If there is an audit score of greater than 8 or other risk factors as above, then we will go for intervention. So from an intervention point of view, we will look at alcohol withdrawal management. So we want to do CWA monitoring. We want to inform the inpatient alcohol liaison team if there is one available in your hospital. We're going to prescribe benzodiazepines. We're going to prescribe IV Pabernex. And after the completion of IV Pabernex, we're going to prescribe oral thiamine. Other considerations, the key investigations again are blood tests, ECGs and echoes. And then the key teams to get involved. So if there's evidence of chronic liver disease, we want to consider hepatology referral, involve dietitians for malnourished patients, and then does the patient require discussion with critical care? So following on from our intervention, we're going to go on to our subsequent management. So in all cases following surgery, we recalculate surgical risk scores at the end and use this to inform post-operative placement as to whether the patient needs an intensive care or a PACU bed or whether they can go to the ward. We also want to ensure that alcohol withdrawal management is in place before the patient leaves theatre. Now, importantly, we also need to consider anaesthetic issues that we might come across intraoperatively. So from an airway or respiratory point of view, we would have a low threshold for tracheal intubation or ASI for general anaesthesia, especially in the acutely intoxicated patients. And we want to avoid hypoxia to help reduce the risk of delirium perioperatively. From a cardiovascular point of view, intoxication and harmful alcohol intake may cause instability, coagulopathy and bleeding. So pre-op, we'd want to consider large bore intravenous access or central venous access, invasive monitoring, blood product availability and vasopressors. Neurologically, we want to have vigilance for withdrawal under general anaesthesia or sedation, a low threshold for depth of anaesthesia monitoring, and cautious dosing of medications and anaesthetic agents, especially if there's cardiac or liver disease present. Then we want to document pre-existing neurology if we're considering regional techniques, have vigilance for electrolyte derangement, and consider acute pain service referral for the post-operative period. So our key learning objectives from today. So we want to understand how to identify and screen patients with an unhealthy intake preoperatively, to recognise patients with unhealthy intake are at risk of perioperative complications, to appreciate patients with harmful chronic alcohol intake or who are at risk of alcohol-related liver disease should have the appropriate preoperative investigations, and to understand risk assessment and decision-making in established alcohol-related liver disease, and that should be guided via the use of validated scoring systems. So our key takeaways: there's always time to do something even in an emergency. You can't initiate interventions if you don't screen, and harmful intake is suggested by an audit of greater than 19 and or consumption of more than 35 units of alcohol per week for women or more than 50 units of alcohol per week for men. And perioperative management includes pre, intra and post-op. So these are just our references that were used. And I will pass it on now to Dr. Hassan for any questions that anybody might have. And this is just a shameless plug as well for our perioperative medicine master's programme at UCLH.